Hi everyone, welcome to our international audience joining session 4 of the World Sepsis Congress. For those of you who don't know me, I'm Naomi Hammond. I'm joining you from Sydney, Australia. I'm an Associate Professor and ICU Nurse Researcher with the George Institute for Global Health at Royal North Shore Hospital in Sydney, Sepsis Australia and the Asia Pacific Sepsis Alliance. I'd like to thank our sponsors who've made this Congress possible today. This session will focus specifically on hypervolemia and how it potentially increases mortality in sepsis. We have a great lineup of speakers today. Our first presenter, Professor Manu Malbrain, is a pre-recorded session, so we won't be able to have live questions. But for the other speakers, they'll be presenting live and we'll be able to take questions. So please add your questions to the chat and they can be highlighted to me to ask if you add Q and colon in front of your question. So let's begin now. So I'd like to introduce Professor Manu Malbrain. He's an intensive care specialist and former ICU director, and probably most well known to us all as the co-founder and president of the International Fluid Academy. And he will talk on the desired and undesired effects of fluid. So over to you.
Thank you for the kind invitation to share with you desired and undesired effects of IV fluids. I'm Manu Malbrain from the Medical University of Lublin in Poland. These are my conflicts of interest and the co-founder of the International Fluid Academy. So let's kick off with an introduction, as the debate on fluid management is continuing, because it's about finding the balance between hypervolemia, avoiding fluid overload and accumulation, and hypovolemia, avoiding tissue hypoperfusion and convective problems. Both can lead to organ failure and dysfunction like AKI, so it's finding the balance between Scylla and Charybdis as stated in the editorial. If I would ask you whether fluids should promote stroke volume or tissue perfusion, I think it's key that fluids initially are administered to increase stroke volume, as this defines a fluid responder. So the macrocirculation is important, but of course the microcirculation is equally important, as oxygen needs to get to the tissues by cardiac output. Sepsis is a time-critical emergency and the clock is ticking. This in analogy to myocardial infarction, where you have a 90-minute door-to-needle time, or ischemic stroke, or polytrauma, where we need to have a full-body CT. Likewise, for sepsis, we may have 1 hour to administer antibiotics and IV fluids. So maybe we have this kind of window of opportunity and a golden hour to preserve organ perfusion. Where does all this come from? Well, the fact that we are giving fluids, and a lot of fluids, comes from the blue stage of spasmodic cholera, where we saw that these patients were profoundly hypovolemic and fluids are life-saving. So it's kind of deeply ingrained into our brain and culture. I'm very happy and proud to share with you that the book on rational use of IV fluids has been released under the open access and already been downloaded over 555,000 times, which tells me that if things are free, people like it, but it also tells us there is a huge interest and knowledge gap to understand more about fluids, fluid therapy. Let's move on to the importance of stroke volume. I alluded that we needed to define a fluid responder, and it determines oxygen delivery to the tissues. Cardiac output is key and is defined by stroke volume times heart rate. So by definition, if you would like to treat a shock patient and assess fluid responsiveness, you must measure cardiac output or stroke volume. Cardiac output then drives the oxygen delivery as well as blood pressure. Blood pressure in humans and mammals is quite high, and this is related to the waterfall effect. As we have the cardiac output pumping the blood to the peripheral organs and tissues, we have the mean arterial pressure, central venous pressure, the mean systemic filling pressure, and the gradient determines venous return, the pulse pressure at the level of the organs where there is a drop, and we have a perfusion pressure, which is at the level of the arterial line. So preload is key, venous return, afterload, as well as contractility. And at an individual organ, we have both the forward pressure, like the perfusion pressure, as well as the back pressure at the venous side. And in conditions of intra-abdominal hypertension, for instance, with increased renal venous pressure, perfusion pressure will be low and organs may be at risk. If we look at Starling relations, we can define a fluid responder, intermediate patients, and fluid unresponsive patients with respect to the relation of preload and stroke volume. Therapeutic options we have in the ICU is either giving fluids, inotropes, or pressors, but the initial reflex, and also according to the guidelines, is often to give fluids. This may bring us to a therapeutic dilemma, which is a situation where there are more than one options for management, but each may carry a potential of harm. Let's move on to chapter 3, addressing some concerns, as we know that one size does not fit all, especially when it comes to the initial resuscitation from severe sepsis. So let's have a look at some definitions. Fluid overload leads to hypervolemia, hyperhydration, and peripheral edema. And we know that hypervolemia is always associated with peripheral hydrostatic edema. The opposite is not true. It's not because you're edematous that you're also intravascularly hypervolemic. So that's why Jean-Louis Vincent suggested we should avoid the term fluid overload. And everything you need to know about deresuscitation can be found in this open access paper, where we suggest the term fluid accumulation, which is any increase in fluid in relation to admission body weight, and you can calculate the actual weight or the cumulative fluid balance, or maybe other parameters like bioelectrical impedance analysis. When it comes to body fluid composition, most of the fluid is intracellular, 1/3 extracellular, and this is when we talk about fluid accumulation, increase in interstitial fluids, whereas increases in intravascular fluids relates to hypervolemia, and sometimes there is a bit of confusion within these terms. Fluid accumulation syndrome can then be defined as any degree of fluid accumulation that has a direct negative impact on end organ function and may be associated with a global increased permeability syndrome, capillary. So, FAS, fluid accumulation syndrome, is a syndrome. It's not a disease. It can occur within many disease states, but most surgeons, anesthetists, don't care about perioperative FAS enough. Let's illustrate this with a typical case of abdominal sepsis, perforated viscous, and patient has a low urine output, get a bag of saline, a low blood pressure, get another bag of saline, and then maybe CVP is low. At the end of the day, the patient may have received 5 liters of saline, needed or unneeded, because it's kind of a reflex. Whenever something goes wrong, give a bag of saline. So on day 2, we see that the abdomen is distended, creatinine is increasing, and on day 4, further increasing creatinine, positive cumulative fluid balance by 7 liters, urine output drops, and CVVH is started. And by day 7, sudden cardiac arrest in the ICU, decompressive laparotomy because of acute mesenteric ischemia and abdominal compartment syndrome. Intra-abdominal pressure is a killer. But the question is, did you measure intra-abdominal pressure, or did you even try to do everything to prevent fluid accumulation syndrome and as a result intra-abdominal hypertension? Did you think fluid stewardship? Let's move on to the diagnosis. As we know that hypovolemia is bad, we need to assess fluid status as well as fluid responsiveness. So the prediction of fluid responsiveness is key, as illustrated in this paper written together with Xavier Monet and Michael Pinsky, where we give an overview of the different fluid responsive tests like passive lag race, functional hemodynamics, as well as others with different thresholds to define positivity. So fluid responsiveness can be associated with low or high preload status. At the other spectrum, fluid overload or accumulation can or cannot be accompanied with very important or very little capillary leak or a global increased permeability syndrome. In between is a new term which called fluid tolerance, which is the maximum amount of fluids that we can give to a patient without causing harm. And the interplay between fluid responsiveness and fluid tolerance will determine the risk for fluid accumulation syndrome. So that's why the fluid status is important. It matters, but there are a lot of myths and misunderstandings, as not all septic patients are hypovolemic. And as I told you, peripheral edema does not mean that we need to give diuretics because of hypervolemia. And it's not just because you're fluid responsive that fluids need to be given. Remember that at the very early stage of sepsis, patients may just be vasoplegic. Let's move on to breaking some bad habits, as fluids are indeed a double-edged sword. They have indications, contraindications, beneficial, desirable, and undesirable effects. But as a doctor, first, we mustn't do any harm to our patient and consider fluids as drugs. There are only 4 indications to administer fluids: for resuscitation to save lives, for routine maintenance to cover the daily needs of water, electrolytes, glucose, for replacement when there are excessive losses like GI losses and burns, for nutrition to cover the daily caloric needs, but A fifth reason we give fluids is to dissolve other drugs in, like antibiotics, painkillers, antacids. And we must remember that every fluid we give will be redistributed, so we have to reassess volemia and fluid responsiveness. And in this study by Niels van Regenmodel and co-workers, 15,000 patients, they looked at all fluids administered to ICU patients, 3% for blood products, 6% only for resuscitation, routine maintenance replacement, 25%, nutrition, another 33%, and another 33% is defined as fluid creep. Fluids that seep into the patient without the intention for administering them, but in relation to administer other drugs, like, as I said, antibiotics. So we know all the big fluid trials going from SPLIT and SALT and SMART and BASICS and PLUS. And in this recent meta-analysis, pooling data of about 35,000 ICU patients, the bottom line was that balanced solutions result in a 1% reduction in mortality, ranging from -9 to +1, with a 90% probability. And they were associated with less major adverse kidney events at day 30. If you combine the trajectory from the emergency room and ICU, there was even a greater beneficial effect, especially in sepsis, burns, decay, but not in traumatic brain injury, where saline still has a place. So maybe it's about time to stop abnormal saline. Why it's abnormal? Because you and I, we don't have 154 millimoles of sodium nauchloride in our blood. It results in delusional hyperchloremic metabolic acidosis, sodium retention, and fluid accumulation syndrome. Fluid accumulation at the outside will mirror fluid accumulation at each and every organ. This will result in venous hypertension and venous congestion and organ failure, and this is what we refer to as a global increased permeability syndrome. So it's of tremendous importance to use the right targets, triggers, and safety limits in order to reach our goal, which is to avoid fluid accumulation syndrome and GIPS. So this brings me to the ROSE model of fluid therapy, dynamic phases of resuscitation, optimization, stabilization. So we have a positive fluid balance, then we have a neutral fluid balance, and then we have a negative daily fluid balance, resulting in a neutral cumulative fluid balance. And this is summarized in the paper on everything you need to know about deresuscitation. We give some hints, tips, clues, triggers to start IV fluids when the patient is in shock, when to stop them, when the patient becomes fluid unresponsive, when we start fluid removal when there is fluid accumulation syndrome or GIPS, and we stop fluid removal when, again, hypoperfusion occurs. So fluids are drugs, and we are humans, and humans make mistakes, but let's forget the mistake and remember the lesson. Stop using abnormal saline and start thinking fluid stewardship. We need to personalize and better individualize the treatment for our patients and identify the unique patient that may benefit from fluids or fluid removal. Give them not too little, not too much, not too late, but the right fluid for the right patient at the right dose at the right time. So to wrap things up, I hope, ladies and gentlemen, that I have convinced you that IV fluids are not just innocent bags of water. No, they are not. They are drugs. They come with indications and contraindications, and see them as a double-edged sword with desirable improving organ perfusion and undesirable risk of fluid accumulation, venous congestion effects. Having said that, I invite you to join the International Fluid Academy. Thank you for your attention.
Fabulous. Thank you very much, Professor Malbrain, for your in-depth talk, which was an excellent introduction into our session this evening. Now, as I mentioned, that was a recorded talk, so I'll now move to our next speaker. I'd like to introduce our esteemed speaker, Professor Sheila Myatra, who is a critical care consultant at the Tate Memorial Hospital in Mumbai, India, and immediate past president of the India Society of Critical Care Medicine. And so Professor Myatra will present on diagnosis and management of hypervolemia in sepsis. Thank you, Sheila.
Thank you very much, Professor, for that, Hammond, for that very kind introduction. I'm going to be speaking about the diagnosis and management of hypervolemia and in sepsis, and I'm sure there'll be a lot of overlaps with the previous speaker. So just to come to the diagnosis, of course, there are various signs and symptoms as you move from hypervolemia to hypervolemia when you're resuscitating a patient of shock, breathlessness, edema, hypertension, heart failure. But these are very non-specific sometimes. Even if you look at clinical examination, and say, for example, in a patient with heart failure with low ejection fraction, the combined sensitivity of RALs, edema, elevated mean JVP to detect a pulmonary capillary vest pressure of more than 22 was just about 58%. And a meta-analysis of 22 studies has shown that the pooled sensitivities to diagnose congestive heart failure also are fairly low. So while clinical examination does help you, it's not very specific or very sensitive. We do look at central venous pressure. Now, central venous pressure may be considered as a marker of volume status. There are, of course, limitations in the way that we measure this. And a high CVP definitely suggests that the volume status is high or normal, or that the right ventricle is failing, and that fluid administration is potentially harmful. But when you have, say, a median CVP value, you don't really get much information. But another place where it's useful is changes in CVP, because this is also informative. For example, if your CVP increases a lot without improvement in the cardiac output, it may indicate that fluids may not be well tolerated. And this graphic has already been shown by Prof. Malbrain, and I think it's a very nice summary of the different organ systems and what you find in patients with hypervolemia. And as you can see, these areas marked in green, these are things that are not very evident when you look at the patient. For example, cerebral edema or renal interstitial edema. But there are other parameters that you can measure easily. For example, you can look at a blood gas or extravascular lung water. You can do echocardiography. You can look at, intra-abdominal pressure. You can look and measure the CVP, or if you are doing transpulmonary thermodilution, extravascular lung water, global end diastolic volume. So there are various measurable parameters that you can use more objectively to assess whether the patient is moving towards hypervolemia. Now, Prof. Malbrain talked about fluid tolerance. Now, what is this fluid tolerance? It's basically the degree to which a patient can tolerate the administration of fluid without causation of organ dysfunction. But this is often misunderstood by a lot of people, thinking that this is about, how much fluid the patient can take in, or how much more fluid you can give a patient. So I really like to call this the risk of fluid administration, because we're not really waiting until organ dysfunction, but we have to be really vigilant in those patients who are at a risk of fluid administration. Now, this was a very nice review that we wrote in intensive care medicine that was led by Daniel De Becker, and I was very proud to be a part of this review. And it's on how assessing the hemodynamics can help to assess the volume status. And I'm going to allude to a few things that are mentioned in this review. Now, you can use X-ray and biomarkers, of course, but when you use X-ray, it's intermittent, and again, interpretation can, be difficult. You're unable often to differentiate between, fluid overload and also permeability edema. Even pro-BNP can be used. It's got an excellent negative predictive value and some prognostic value. Ultrasound can be really useful. And when you're looking at mechanically ventilated patients, there are specific things that you can look at. For example, a round shape and dilated, IVC and minimal respiratory variations, or you can look at even the diameter, and a diameter more than about 23 millimeters, can be suggestive of hypovolemia. And not only ventilated patient, but even in other patients, there are various parameters you can look at, especially those who are good at advanced echocardiography and more specific objective way of looking at hypovolemia and increased cardiac preload. Lung ultrasound can also give you valuable information, and this is more real time. You can look at, edema fluid. You can look at B lines. You can also look at the presence of fluid, effusions. More newer now is the venous excess ultrasound, or the VEXIS that we're talking about, where you're also looking at venous status. You're looking at the hepatic vein, the portal vein, and intrarenal, and there are different grades of this VEXIS grading. Of course, needs to be more extensively studied before we can absolutely adapt it into clinical practice. And then as you're giving more and more fluid to this patient, you need to look at more advanced hemodynamic monitoring. And one of the ways is to put in a PICO or look at transpulmonary thermodilution, which can give you very valuable information. And you can look at the extravascular lung water index. And of course, this calculation is based on complex analysis of transpulmonary thermodilution curve using PICO. And you get a set of values on this monitor. You can look at the global end diastolic volume index, and this is a measure of the preload, and these are the normal values. And you can look at the extravascular lung water index. And again, when the extravascular lung water index, the cutoff values are about 7, or you can move up to 10. And this again tells you it may be because the capillaries are more leaky, or it can also tell you about the volume of the fluid that has extravasated. Then you can look at intra-abdominal pressure. Now, this onset of organ dysfunction usually occurs when it's more than intra-abdominal pressure is more than 20 millimeters. So if we're able to measure it using specific tools, then the MAP minus the intra-abdominal pressure can tell you about the abdominal perfusion pressure. And especially if this is caused because of hypovolemia, then we can be more vigilant and careful about this, and that can help us diagnose. Now, the principles of management is also going to be covered by the next few speakers. But broadly, in my mind, first, of course, you need to treat and control the sepsis and also the underlying conditions. For example, the patient may have cardiac failure or renal failure, and this will again contribute to the hypovolemia. So it's not about just limiting the fluid or getting the fluid out. It's also about treating the sepsis and controlling these conditions. Then, of course, you need to stop or limit the further administration of fluid once you diagnose hypervolemia. Early use of vasopressors, which Professor Teboul is going to talk about, because you need to do something to treat shock if you're not going to give more fluids. And then, of course, active fluid removal by either diuresis or dialysis. You can use SLED and other modalities for active fluid removal. Now, when you look at the fluid administration, I'm going to talk largely about restricting the fluid. It's a vicious cycle, as we all know, because when the first measure that you do during when you see a patient in septic shock is, of course, the fluid resuscitation. And as you aggressively resuscitate, this is a vicious cycle of intestinal edema, visceral swelling, intra-abdominal hypertension. And when there's oliguria, again, you give more fluid. And this intra-abdominal hypertension can result in mesenteric vein compression, venous hypertension. So it's a vicious cycle where, you can go into a downward spiral with this, aggressive fluid resuscitation. And it's interesting, and this is an old review that shows that almost half the patients to which we give fluid are not really fluid responsive. So a lot of patients just get arbitrarily a large amount of fluid, and this may result in hypervolemia. And therefore, determining which patient will be fluid responsive is really, really a challenge, because on one side, you do want to give volume and correct the hypotension, while on the other side, you don't want to push the patient into pulmonary edema, hypovolemia, and other conditions. And therefore, when you ask yourself that should I be giving more fluid, what you really want to know is that by giving more fluid, is the cardiac output going to increase, or is this patient fluid responsive? Because if the patient is not fluid responsive, there's no benefit of giving fluid, and we may actually cause harm by precipitating hypovolemia. Now, when you look at the relationship of the Frank-Starling curve and the Marek-Phillips curve, and here you will see that, when you're in the steep, as you go onto the steep part of the Frank-Starling curve, increase in the preload does not result in further increase in the stroke volume. And, in these patients, when you're already on the steep part of the curve and the ventricle is already full and the compliance is low, there is a curvilinear relationship with the stroke volume, and you can have a steep increase in the extravascular lung water and large increases in the filling pressure. And therefore, you have to be very careful. And this might also be accentuated in patients in sepsis where you have more leaky capillaries. So if you look at the interrelation of the vascular pressures, the extravascular lung water, and also the venous status with the volume status, where as you're moving from a hypovolemic patient to a hypervolemic patient, it's more a curvilinear relationship. And again, the extravascular lung water index and the venous status depend on the heart cardiac function. Extravascular lung water index also depends on increased permeability, and your venous status can also depend on your increased intrathoracic pressures. So it's really important when you should give and not give fluid. Of course, you need the presence of acute circulatory failure, because if you're not in shock, there's no need to really give fluid. You need the presence of fluid responsiveness. And most important, even if a patient is fluid responsive, there should be no major risk of giving you fluid. So your answer to all these questions should be yes before you consider giving more fluid to these patients. Now, fluid responsiveness, or rather, I would say fluid unresponsiveness, should be assessed in these patients who you diagnose to be hypovolemic. And this is really important. And there are various tests that you could do to perform these. And these are the commonly ones used in clinical practice, like passive leg raising, pulse pressure variation, stroke volume variation, tidal volume challenge, IVC, looking at the respiratory variation in IVC collapsibility, or end expiratory occlusion tests. And each one has their limitations, but these are the ones that are most well demonstrated. But what's most important to remember, that every fluid responsive patient does not require fluids. So the presence of fluid responsiveness alone is not a reason to give fluid. And what we really need to see is whether there are any major risks of giving fluid to this patient. So even if a patient is fluid responsive, if there is a risk of giving fluid, you should not give fluid to a patient. Giving fluid to a patient who's not fluid responsive will not give you benefit, but can actually produce harm. And here you've already seen from Professor Malbrain the phases of fluid resuscitation, which he nicely summarizes as the rows with the escalation phase and the de-escalation phases. And he's also provided various, at each of these steps of resuscitation, optimization, stabilization, and evacuation, he's talked about various triggers of when to start and when to stop fluid administration. But I would say that even during these phases of resuscitation, when you're at resuscitation, optimization, or stabilization, even this, when you see during these phases, the first 3 phases, when you see signs of hypervolemia, this should actually discourage fluid administration, while the presence of hypervolemia should actually trigger the de-escalation phase or fluid removal. So I'd just like to summarize by saying that it's really important to diagnose hypervolemia early in whichever phase of resuscitation you are, using the various clinical, laboratory, and imaging techniques that I outlined. And not all of them are very reliable, so you may have to use a combination of these techniques. And it's very important to consider these fluids as a drug, like Professor Malbrain has said, and they should be used with the same caution and respect that you would use any other pharmacological drug. And stop the fluid administration in patients who are not fluid responsive, because this will not produce any benefit, but may actually produce some harm. And most importantly, even when the patient is fluid responsive, do not administer fluid in patients who are at a risk when the risk of fluid therapy is very high. And of course, consider the early use of vasopressors and active fluid resuscitation removal, which the next 2 speakers are going to be talking about. And with that, I thank you very much for your attention.
Thanks so much, Prof. Sheila. That was an absolutely fabulous talk, very comprehensive, obviously not much time to really go into detail. So just people who are online and watching, please put your questions into the chat. There's a few coming through. Sheila, I think I might ask one of the questions here. It's around what are the key clinical manifestations and diagnostic criteria that it could be used to identify hypervolemia in patients with sepsis. So I guess what are some of the key clinical signs that you might be looking for?
Right. So I already outlined, clinical examination. You're looking at patients getting dyspneic, or there's edema, there's on auscultation. You could look at X-rays. You look at imaging. Ultrasound is a really useful tool now, because it's not a static, whereas you can look at a more dynamic way of assessing lung ultrasound and even the cardiac function. So these tools can be used, but again, the presence of edema alone is not an indication to not give fluid. The patient could still be hypovolemic. So that the message shouldn't be that, usually when we look at patients in the intensive care unit, we see they're very puffed up, the septic patients. Yes, you should be cautious because this patient is moving towards hypovolemia, but that's not a reason not to give fluid, because this patient may still be hypovolemic. So if there isn't cardiac dysfunction, or if the lungs are not too bad, you may still consider giving some fluid. So just seeing a patient puffed up is not an indication to just completely stop giving fluid. But of course, you have to be cautious.
Yes, yeah, no, thanks for that. And I guess there's a lot of people joining from different settings around the world, so people in low resource settings. What would you consider to be some key differences that you might consider, particularly if you don't have tools available to you? What could you use? What would you be your go-to tools, I guess, to identify hypervolemia? Yeah.
So especially
in a low resource.
Yeah, resource limited settings, I think it's very relevant. Not because the fluids are expensive, but because if you push the patient towards hypervolemia or fluid overload, you might actually need invasive mechanical ventilation, and this may not be available. And also the response to the fluid may be variable. We've seen the Lancet paper with the African study with children, and other studies that have shown that in different conditions, especially tropical infections that you see in resource-limited settings, the fluid requirement in malaria is not the same as when you see gram-negative bacterial sepsis or fungal infection. So you have to be, the requirements also may be different, and you have to be very cautious because invasive mechanical ventilation is not available. So you have to largely go using clinical assessment, of course. Ultrasound is expensive, but it's a one-time investment. So a lot of centers, even in India, where, people make donations, we have an ultrasound machine and we can actually, it's a one-time investment. So there aren't recurrent costs with that. In a patient with acute circulatory failure, you would at least have an arterial line in. So if you have an arterial line in, you can look at pulse pressure variation. You can also perform the tidal volume challenge, which was developed in our unit. And these tests do not require continuous cardiac output monitoring. And Professor Teboul is here. Even with passive leg raising, you could use this with ultrasound to measure the cardiac output. And recently, he's done a study where he's looked at a drop in pulse pressure variation after looking, doing a tidal passive leg raising and found a good correlation. So these are, if you have an arterial line in, you can still use these dynamic parameters like pulse pressure variation, echocardiography, tidal volume challenge, even the PLR, and you could look at fluid responsiveness. And if they're unresponsive, you could restrict fluids in these patients.
Brilliant. Thank you so much. You've given some great suggestions there, Prof. Sheila. And I think now with the time, we might just need to close there. And thank you once again for your excellent talk. And so I'd like to now move to our next speaker, who is a world-renowned researcher and professor of critical care. So I'd like to welcome Professor Jean-Louis Teboul from the University of Paris-Saclay in France. Professor Teboul will be speaking to us today on if the early use of vasopressors can avoid hypervolemia. So over to you, Professor Teboul.
Thank you very much for this kind introduction. I am Jean-Louis Teboul from Paris, France, and I'm very honored to participate in this very specific event today, and I thank a lot the organizers. So I will try to convince you that early use of vasopressors, and namely norepinephrine, can avoid hypervolemia in sepsis. My conflicts of interest are on this slide. So as you know, in septic shock, it is recommended by the Surviving Sepsis campaign to use norepinephrine as a first-line agent over other vasopressors. And it is a strong recommendation. Also, in the European Society of Intensive Care Medicine some years ago, 34 experts tried to give some recommendations about the use of vasopressors. And one of these recommendations was about the use of norepinephrine. And there was a perfect consensus among 34 experts coming from 11 countries to say norepinephrine should be used as vasopressor of first choice. So all agree about this recommendation. But what about the early initiation of norepinephrine? It is preferred in severe septic shock. And this is one of the statements, one of the recommendations of this European Society paper. And we found a reasonable consensus. 70–80% experts agree on the fact that vasopressor should be started early, means before completion of fluid resuscitation. This is supported by some outcome studies. This is a randomized controlled trial coming from Thailand, where they randomized patients to receive either early norepinephrine administration or delayed norepinephrine administration. The primary outcome was not mortality, but was shock control rate by 6 hours after diagnosis, and the shock control was defined as the MAP above 65 and urine flow above 0.5 ml per kilogram per hour for 2 consecutive hours, or decreased lactate by more than 10% from baseline. And interestingly, they found a better shock control rate with early norepinephrine compared to standard treatment. Another study, which was not randomized, but which was retrospective, but using a propensity score matching, comparing very early norepinephrine administration, means within the first hour of resuscitation, and delayed norepinephrine administration after 1 hour of resuscitation. Look at mortality. The cumulative mortality was higher in the delayed norepinephrine group. And this is a meta-analysis comparing delayed and early norepinephrine administration, again, showing that it was in favor of the early group in terms of shortened mortality, but also in terms of morbidity. So there is no doubt about the use of early norepinephrine in severe septic shock. And how can early norepinephrine initiation improve outcome in septic shock? Of course, by correcting hypotension-induced hypoperfusion, organ hypoperfusion, and this is for sure. But maybe also by preventing fluid accumulation. One of the mechanisms can be by redistributing blood from the unstressed to the stressed volume. And this is supported by some clinical studies. This is one of them coming from my unit with Alpha-Mzawi. We included 105 patients with septic shock, and we gave norepinephrine very early. MAP was low, 54. It went up to 76. Stroke volume index and cardiac output increased, but also the global and diastolic volume index, which is a marker of preload, also increased, and pulse pressure variation, PPV, decreased. So what happened to these patients? Norepinephrine, when administered early, increased cardiac preload and cardiac output and decreased preload dependency, decreased preload responsiveness. And this was confirmed by another study we did with Xavier Monet in our unit. Again, we gave norepinephrine very early. Look at the MAP, which was very low, 49, and it went up to 71. Cardiac output increased, and all the markers of preload, including CVP, increased with norepinephrine. So norepinephrine, again, can increase cardiac preload and cardiac output. But we performed some fluid responsiveness tests. In fact, we performed passive leg raising test twice, before giving norepinephrine and after giving norepinephrine. And before giving norepinephrine, we had a 19% increase in cardiac output during the test. These patients were all preload responders. But after giving norepinephrine, the change in cardiac index decreased to 13. And some patients who were non-responders became, some patients who were not non-responders, because we had 0% non-responders in these patients, became non-responders after receiving norepinephrine during the test. So therefore, again, norepinephrine is able to decrease preload dependence. What happens, in fact? This is a representation of the Frank-Starling mechanism, stroke volume and CVP here. So we started from a CVP at baseline before giving norepinephrine like this, and we perform a first PLR test. And this could increase stroke volume when we increase preload during the test. But when we gave norepinephrine, this shifted CVP to the right, and now the CVP value is at a point where the Frank-Starling curve is flatter than before. And therefore, from this starting point, now, if you perform a second PLR test, this will increase stroke volume to the less degree. And therefore, this explains the results we found. So norepinephrine decreased preload dependency. So the messages of these two studies were that norepinephrine can increase cardiac output, increase cardiac preload, increase cardiac output in preload-dependent patients, and reduce the degree of preload dependency exactly as fluid infusion does. So norepinephrine administered early have the same effects as fluid in terms of venous circulation. And how does norepinephrine impact the venous circulation? Probably by blood redistribution from unstressed to stressed volume. And this is something we address in this study by Romain Persichini and Xavier Monet and others in my unit. We try to assess, to estimate the venous circulation component, venous return component. We gave norepinephrine early again, and we had an increase in arterial resistance in blue, but also an increase in the resistance to venous return in blue here. But we estimated the mean systemic pressure using a sophisticated method in mechanically ventilated patients. We perform inspiratory and expiratory occlusions, and we observe an increase in the mean systemic pressure with norepinephrine compared to without, and also an increase in cardiac index. And in this other more recent study with Imenada, we also looked at the change in PMS induced by passive leg raising before and after norepinephrine administration. And again, we found a more marked increase in mean systemic pressure induced by passive leg raising with norepinephrine versus without norepinephrine. So the messages of these two studies are that in spite of an increase in venous resistance, venous return increases with norepinephrine through an increase in the mean systemic pressure, related to blood redistribution from unstressed to stress volume. And I say this is fine. This unstressed volume is abnormally increased during sepsis and could be further overfilled if you continue fluid loading. So this redistribution of blood from the unstressed to stressed volume can contribute to a reduction of the requirement of exogenous fluid. And this is a way to avoid fluid accumulation. Another mechanisms could be the action of norepinephrine on the heart function. And norepinephrine can increase cardiac contractility, which can reduce feeding pressures and reduce the consequences of feeding pressures on the circulation and the tissues. And this is well supported by this study with Olfheim-Zawi again, what we did in our unit, and we measured all the indices of systolic function of the left and the right ventricles using echocardiography. This is an example. LVEF, left ventricular ejection fraction, increased when norepinephrine was given early, and also the velocity time integral was increased when norepinephrine was given early. And all the indices of the RV and LV functions improved with norepinephrine administered early. And systolic arterial pressure also increased from 88 to 124 on average. And in spite of this increase in systolic blood pressure, which is a good reflection of the left ventricular afterload, all the indices of cardiac systolic function improved with early norepinephrine, suggesting an improved cardiac contractility. What could be the mechanisms? An effect on myocardial beta-1 receptors, which are not yet downregulated at the early phase of sepsis, or an increase in coronary perfusion pressure. So an increase in the DAP, which is the upstream pressure for the perfusion of the myocardial vessels of the left ventricle. And you know that if norepinephrine increases vascular tone, norepinephrine is able to increase DAP. And of course, this can result in less cardiogenic pulmonary edema. And this is what was found in this randomized controlled trial I already talked about. In this study, the incidence of cardiogenic pulmonary edema was less in the early norepinephrine group compared to the standard treatment group. Lower incidence of cardiogenic pulmonary edema, probably explained by these results, by these mechanisms. So does early norepinephrine reduce fluid accumulation in clinical studies? What about the clinical studies? In this study, vasopressors, norepinephrine was given before or after 6 hours. There was no difference in terms of total volume of fluid within initial 6 hours of resuscitation. But in this Chinese study, when norepinephrine was given in the first 2 hours of resuscitation, the volume of IV fluids within 24 hours was less in this early group compared to the delayed group. It was also found in this study where the early norepinephrine administration was initiated 25 minutes after starting resuscitation compared to delayed, here more than 2 hours. And there was a big difference in terms of volume of fluid given during resuscitation, less fluids in the early norepinephrine group. And again, in this study we did with Gustavo Spinatescon and others, we found that the very, very early norepinephrine administration was associated with less resuscitation fluids compared to delayed norepinephrine administration, probably due to all the mechanisms I already talked about. So my conclusion is that early norepinephrine can prevent fluid accumulation by redistributing blood from the unstressed to the stressed volume, and this can result in less fluid requirements, but also by increasing cardiac contractility, which can reduce feeding pressures with consequences on pulmonary edema on the left side, but maybe also peripheral edema on the right side. Does early norepinephrine reduce fluid accumulation in clinical studies? Probably yes, if norepinephrine is initiated very early, within the first hour, for example. I would like now to thank you very much for your attention.
Fabulous. Thank you so much for that presentation, Professor Teboul. There's a lot of questions coming in. There's a bit of a mix around fluids, how much fluids to give. I guess there's some question around hypovolemia volemia versus hypervolemia. But I think I might just start with, it's clear that bringing in inotropes early does reduce fluid accumulation. But how do you actually identify that early need to use vasopressors?
I think that the best way to identify the need of the use of norepinephrine is to look at the diastolic arterial pressure, because the main determinant of the diastolic arterial pressure is arterial tone. And therefore, if you have a low diastolic arterial pressure, for example, around 40 liters of mercury or less than 40, you can be sure that arterial tone is depressed. And therefore, it is usually to think that fluid alone can restore MAP in this condition, because you need to help by giving norepinephrine to help the treatment to increase MAP and to achieve your target, which would be above 65, 70 meters of mercury of mean arterial pressure. Diastolic arterial pressure as a trigger of administration of norepinephrine.
Yeah, brilliant. So what about, there's a question that's come through, and it goes back to Sheila's talk as well, but really, is there different considerations in different patient populations in respects to how you might treat? So the example was given in palliative care patients. Would there be different considerations?
I think that if you identify sepsis, if you identify septic shock, I think that in all cases, you should use norepinephrine vasopressors, again, by looking at the diastolic arterial pressure. It could be very effective in patients with coronary artery disease, because these patients can benefit from an increase in DAP to improve their myocardial perfusion. But there is we cannot reserve this to some patients and not use in other patients. I think that if DAP is low, this is time to give norepinephrine. And that's it. So in any patient, and fortunately now we have good data to think that we can start norepinephrine using a peripheral venous access. It is not necessary to put a central venous line to introduce norepinephrine. You can use peripheral venous access, and now the Surviving Sepsis campaign also suggests that this is a good route for norepinephrine with no or almost no major adverse events.
Absolutely. Perfect point, and a great one to end on. And I'd just like to thank you again for your wonderful lecture, Professor Jean-Louis. And I'll now move to our next speaker, who is joining us from Sao Paulo in Brazil, Professor Ludhmila Hajjar. She's a specialist in emergency medicine and intensive care and cardiology, and will be presenting to us today on the safety limits to stop fluid infusions. So thank you very much, Professor Hajjar. Over to you.
Thank you very much. It's a pleasure. I'm honored to be here talking about such an interesting topic, which is how to avoid hypervolemia. My topic is the safety limits to stop fluid infusions. How can we lead with this challenge at bedside? As we know, when we're leading with patients with septic shock, we have the mainstay of treatment, which is based on hemodynamic resuscitation, and also in the specific treatment, which is based on antibiotics and the focus drainage and others. When we are looking at the hemodynamic resuscitation, the aims of the treatment are based on fluid infusion and vasoactive drugs. And we know that we must be fast, we must be early, and we must be adequate. As we know that within the last years, we moved from 6 hours of the best treatment to 3 hours. And now for the 1 hour, we have the lowest time to increase hemodynamic goals and to best achieve what we need to improve perfusion to avoid organ failure in these patients. However, we have already discussed this before, that we have, unfortunately, the vicious cycle of septic shock resuscitation, which is a consequence of overload, of the increased permeability, and patients can present with intestinal edema, with visceral swelling, hypertension, oliguria, vein compression, venous hypertension, and this will lead to organ failure. We have a balance between hypovolemia and hypervolemia that we must lead with. If one side we have all the consequences of hypovolemia, of course, we need to call attention of the reduced tissue perfusion on this side. We have in the excessive fluid administration consequences, further complications, most basically on edema. So we must lead with this at bedside, and we need to avoid fluid overload, as we had already showed with Malbrain presentation. We must avoid the complications of pulmonary edema, of hyperchloremic acidosis, and increased acute renal failure in CDC and all complications as consequence of fluid overload. When we are at bedside, we must ask in which phase my patient is when I have to lead with fluid assessment. This is recently published review paper that I had the pleasure to be with Daniel De Baker and Mauricio Cecconi, where we call in attention again the 4D of resuscitation. So when we have to lead with fluid infusion, we must ask in which phase my patient is, in the salvage, in the optimization phase, in the stabilization, or in the de-escalation. Why? Because we know that fluids are drugs, and we must take into account the type of fluids, the rate of fluid infusion, the objective of fluid infusion, and also the limits. And about the limits, we must take into account even the status, the clinical status of the patients, but mostly based on the assessment of filling pressures and complications of fluid overloads. When we're looking at bedside and I have a patient in the resuscitation phase, the aim of the fluid is to resuscitate, is to avoid a life-threatening condition, and I must achieve the adequate perfusion pressure. In the optimization phase, we must administrate fluids according to the individual needs. In this phase, we usually recommend hemodynamic monitoring to better individualize which types and how much fluids I must give in this phase of treatment. In the stabilization, in the evacuation phases, usually we don't prescribe fluids. And we must take into account when you are talking about the stop of fluid infusion, in which phase my patient is based also in pathophysiology, which will lead to more edema, to more fluid overload, because we have hits. We have the hits of increased permeability syndrome, and we have a hit of hypoperfusion. So we must balance between hypoperfusion and fluid overload and the consequence. How much fluids must I prescribe at bedside? It depends on how my patient responds to my fluid infusion. And what we recommend is that we look again to the Frank-Starling curve to better understand where my patient is. If my patient responds to the fluid infusion, the cardiac output increases, and the filling pressures are maintained, my patient is fluid responsiveness. On the other hand, if my patient increases filling pressures and the cardiac output has not increased, my patient will not answer my patient is not fluid responsiveness, so I must stop fluids. This is better personalization type of monitoring at bedside to better understand, to assess the fluid responsiveness. A good way to evaluate how my patient can respond to a fluid assessment is to infuse a volume of 250 ml of crystalloid infusion. This is a better way to understand who will be the patients who will respond to a fluid infusion. There are other ways to better understand at bedside. We must talk about the passive leg raising, because this is a method where we can avoid the fluid overload in patients who will not respond to fluid infusion. In this case, we make a kind of a leg raising, and we have about 20 clinical studies which show that this test can predict fluid responsiveness with accuracy of 95%. So in the case of patients who will not respond to the fluid infusion, patients will not have the bad consequences of fluid overload. How can I measure this? The best way is to have at bedside the best hemodynamic monitoring for my patient at that clinical circumstances. It depends on the patient, on the severity of shock, in the cardiac function. So we have lots of monitors to better understand who are the patients who are fluid responsiveness and when we must stop to infuse fluids. The kind of monitors depends on cardiac function, depends on pulmonary permeability. At bedside, we use minimally invasive monitors with echocardiography for the most patients. However, patients with the most severe cases of shock or who present LV dysfunction, we must consider transpulmonary thermodilution. Of course, there is an interrelation of intravascular pressures, of extravascular lung water, and venous status according to the volume status. And in the normal cardiac function patients, the volume and pressure, they have a good interrelation. However, in patients with impaired cardiac function, we will have increased permeability, we will have increased intrathoracic pressure, so these patients will present with hypervolemia and more consequences of the fluid infusion. How can I do this at bedside? This is a good way to evaluate when to stop fluid infusion. In this side of this figure, in this case, I performed fluid challenge over 5 to 10 minutes, and in the case of the filling pressures increase excessively, I stop the fluid infusion. And so I keep treating the patients, vasopressors, dobutamine, and others. In the case of the cardiac pulmonary, and the cardiac output does not increase, probably my patient did not have a benefit of more fluid challenge. So this is a way to evaluate at bedside when to stop fluid infusion. Considering the phases of shock, I can evaluate how can I administrate fluids, which are the goals, and which are the limits. If at one side I have the pressures to measure with the monitors, I have the clinical findings of edema, of congestion. So in this case, I must stop fluid infusion. This is a bedside diagram to better evaluate these patients. If my patient have an indication for fluid administration based on clinical signs of hypoperfusion, I will assess fluid responsiveness. How? With a proof of crystalloid of 250 ml, as we have already discussed. In the case of my patient present an increased cardiac output with minimal change in CVP, in extravascular lung water, in the systolic volume, my patient responded to fluids. So the fluid administrations may be useful for these patients. In the case of no change in cardiac output, and in the case of minimal change in the pressures and volumes, these patients have an uncertain response to fluids. So I can move on to the next steps to reevaluate later these patients according to hemodynamic status. However, on the other side, if my patient presents no increase in cardiac output and the filling pressures increase, the volume increases, the fluids were not tolerated, so I must stop fluid administration. Another tool which is very useful at bedside, is the extravascular lung water that I can measure with echo, with X-ray, I can guess, and of course, I can measure with with transpulmonar thermal dilution. In the case of extravascular lung water increased, probably my patient has already hypervolemia or a decreased cardiac function. So I must take into account to stop fluid infusion. Echocardiography at bedside, the PPAHS, is also a useful tool to evaluate when to stop. Depending on if my patient is in spontaneous breathing or if it's mechanical ventilation patients, I can use variations in inferior vena cava, the flows in hepatic, portal, and renal vein, and other evaluation of diastolic function with echo, and we will better understand when to stop fluid administration using echo at bedside. So in conclusion, we know that we must be early in the bedside management of shock, but we should not to do harm. So we must know when to stop fluid infusion. Thank you very much.
Wonderful. Thank you so much, Professor Hajjar, for that wonderful lecture. There's a number of questions, and really I should have asked this to all our speakers, and it goes to, everyone's talking about fluids, but no one's saying what type of fluid. So there is questions around what type of fluid would you use. We know you've already mentioned about the volume. That was another question, that you do a 250 ml challenge. But maybe if you just give your opinion on what type of fluid should be used.
Thank you very much for words. And in the last years, we have many trials comparing crystalloids with colloids, and other many trials comparing unbalanced solutions with balanced solutions of crystalloids. And now we moved on to use more crystalloids and more balanced solutions. Why? Because colloids have not shown any benefit when we compare to crystalloids regarding mortality, acute renal failure. And when we compare crystalloids, the balanced solutions with unbalanced solutions, the balanced solutions are associated with decreased mortality and with the reduced incidence of acute renal failure. So now we use more balanced crystalloid solutions in the early phases of treatment of septic shock patients.
Fabulous, thank you. And I'll just ask you one more question. It was around your clinical optimization flow chart. A question from Cameroon came in around how do you do that type of evaluation in centres where there's no sophisticated monitoring equipment available at the bedside?
Sure. I think the best way to optimize patients on this phase, if we have everything available, is to have a cardiac output monitor. This is the best way. But we know that there is a lack of resources around the world, and many times we will only have CVP, gas analysis, and echo. But we can do it using these parameters because we will optimize based on SVU2, based on the correction of acidosis of clinical parameters, and also using echo, because with the echo, we can measure VTI and we can measure filling pressure. So we'll know when to administrate fluids, how much, and when to stop.
Fabulous. Thank you so much for that response and for your lecture overall. I'm now going to, thank you, Professor Hajjar. I'm going to now move to our last speaker in this session, another world-renowned clinician researcher, Professor Marlies Ostermann, who is a Professor of Intensive Care and Nephrology at Guy's and St Thomas's Hospital in London, who will talk to us now on fluid removal, when and how. So thank you, Professor Ostermann.
Good morning, good afternoon, good evening, wherever you are in the world. It's a great honor to contribute to this meeting and to this very important session. And in the next 15 minutes, I will talk about fluid removal. I have no particular conflicts of interest related to this talk. It's very humbling to follow the series of excellent speakers and talks. And there will be a little bit of repetition. Again, I want to start with some general introduction and remind everybody that fluid removal is part of the fluid therapy, and as elegantly shown by Professor Malbrain and others, once patients are stabilized and optimized, fluid removal should be considered. And we consider and think about fluid removal because we want to avoid fluid overload and fluid accumulation. And if we get this right and avoid indeed fluid overload, then we can shorten the duration, we may prevent organ dysfunction and need for organ support, and we hope that this improves outcomes as elegantly shown by previous speakers. But clearly, there's no question, if we get this wrong and remove fluid inappropriately and derail what has been done during the resuscitation, then we could risk instability, hemodynamic instability, we may even risk organ ischemia, and we may have side effects from our methods, whether it's diuretics or ultrafiltration. I'd like to remind everybody that fluid removal, or also called de-escalation of fluid therapy, is an active process, and it requires a thoughtful thinking, a clinical assessment, depending on the evaluation of the patient's clinical condition and the aims of therapy, and importantly, regular review for effectiveness and safety. And so in the next remaining 10 minutes, I will just talk about when and how to do this. When talking about when, it's important to remember that the fluid given during the resuscitation, and as elegantly shown by previous speakers, obviously enters the vascular space, and we hope that it improves organ perfusion. But during critical illness, and particularly during sepsis, often the fluid doesn't remain in the blood vessels, and for various reasons, fluid quickly leaks out because the endothelial layer is dysfunctional, the glycocalyx may be disturbed, and there's increased vascular permeability. The vascular tone may also be reduced. And as a result, a lot of fluid that we give ends up actually in the wrong space. It leaves the vascular space very quickly, and the majority of fluid given ends up in the interstitial space. If we're now planning to remove fluid, we have to remember this, because we can only remove fluid, whether we use diuretics or extracorporeal therapies, by accessing the vascular space. Diuretics or extracorporeal measures remove fluid from the vascular space. Now, the majority of fluid may have accumulated in the interstitial space, so we rely on adequate fluid shifts from extravascular back into the vascular space. And as such, we can only really safely remove fluid as long as there is an adequate fluid shift. Otherwise, the patient will become intravascularly hypervolemic and unstable. And the maximum capillary refill rate varies between patients. But as a principle, we should only remove fluid at a similar rate or a bit less as fluid can be physiologically returned to the vascular space. Now, the risk of hemodynamic instability is high if we remove fluid faster than fluid can be shifted back. The risk is also higher if we clearly remove more fluid than necessary. It's higher in patients who have lost vascular tone and can't vasoconstrict themselves. And obviously, clearly, it is higher in those who already have additional cardiac dysfunction. And then lastly, fluid shifts are reduced in patients with low oncotic intravascular pressures. That all is there. I say all this to highlight that fluid removal is an individualized process and depends on the condition of the patient and needs to be personalized. And in this review, led by Professor Malbrain, again, he highlighted the importance of doing an individualized assessment. If you go to the literature and try to find out the triggers for optimal and timely fluid removal, it's very disappointing, as was shown in a systematic review led by Jonathan Silverside in Belfast. So the team looked at the existing randomized controlled trials that had been in sepsis or ARDS. They identified 11 randomized controlled trials looking at fluid management and in particular fluid removal or de-resuscitation. And it was disappointing to see that in these randomized controlled trials, the majority of studies did actually not attempt to use specific physiological criteria. And it was impossible to judge exactly what triggers they had used. Based on that, we rely at the moment really on expert opinion and the opinion of and expertise of world leaders in the field. And by consensus and pragmatically, we can say that fluid removal is something to consider when patients no longer need fluid resuscitation and are adequately resuscitated, when they're no longer fluid responsive, and when there is additional evidence of fluid accumulation. But importantly, edema does not mean that patients are able to tolerate fluid removal, and a positive fluid balance also does not mean that fluid needs to be removed. And in this review led by Professor Malbrain, the figure gives a bit of guidance on when to consider, say, fluid removal. And as you can see here, these triggers really relate to hemodynamic parameters, indicating and assuring that fluid removal may be conducted safely. Ultimately, at this moment in time, it is when to do it is a decision at the bedside based on the individual parameters and the goals of therapy. The next question is, how would you do this? Well, we have various options. We can either use diuretics, and most of us are very familiar with diuretics and know the advantages, and they're generally available worldwide. But it has to be remembered that fluid removal is less predictable. We have to hope that the kidneys work and produce a bit of extra urine. We have to remember that the urine that is produced is then hypotonic and is not like plasma, so sodium often stays behind. Clearly, with any diuretic, there is a risk that patients may not respond, and as such, patients may remain fluid overloaded for longer. The extracorporeal strategies have the advantage that we can dial in how much fluid to remove, and we remove plasma, so water and sodium and other electrolytes. We can also, if we want, remove solutes, but it's a major step up in invasiveness, in cost, and in workload for the people at the bedside. If you look at the literature and try to figure out whether diuretics or extracorporeal therapies are advantageous, it's very disappointing, because the studies which have been conducted are all different. They use different strategies, and not many studies looked at subgroups of interest, like patients with acute kidney injury or patients on mechanical ventilation. And this is probably a reflection of the fact that fluid removal is quite a complex issue. And just to illustrate this, I want to show you the details of the RADAR trial, the most recent randomized controlled trial in this field, where the team looked at mechanically ventilated adult patients who had been in the ICU for up to 48 hours. And they wanted to compare active fluid removal, a strategy of de-resuscitation, with usual care. They excluded patients who were unlikely to respond to diuretics, like patients with end-stage kidney disease, and they also excluded patients who had very specific fluid needs, like patients with diabetic ketoacidosis or hyperglycemia. And in this trial, they monitored patients. All of them had a conservative fluid administration. All of them were monitored regularly. And if they met eligibility criteria, they were randomized. And eligibility criteria meant they were considered to be adequately resuscitated. They had evidence of fluid accumulation in at least 2 areas, and they had no contraindication to fluid removal. So they were adequately resuscitated and were considered to be able to tolerate fluid removal. If they were then randomized to either usual care, led by the clinicians, versus a protocol of de-resuscitation, where patients received diuretics, aiming for a particular urine output, aiming to get the patient at least 1 to 3 liters negative every day. And if diuretics didn't work, patients would be considered for renal replacement therapy. But renal replacement therapy was not mandated, it was suggested. Now, the trial showed really little difference in fluid intake, as demonstrated in their paper. The only difference was that patients in the usual care received slightly higher volumes of maintenance fluid. But apart from that, there was little difference with regards to fluid intake. But there was a big difference in output, and patients randomized to the intervention arm passed more urine, either as a result of diuretics or had a higher ultrafiltration rate. And as a result, they achieved a negative fluid balance more easily within 5 days. So it was feasible to do this. It was possible to randomize patients to an active fluid removal strategy. It was a feasibility trial, and as such, there was no major difference in any of their hard outcomes like mortality or ventilator-free days. But it was reassuring to see that this trial could be conducted. However, it also needed to be remembered that they had a lot of protocol violations. In the intervention arm, not everybody received the diuretics as prescribed, and not everybody was considered for renal replacement therapy because it was considered to be too invasive. Plus, a lot of patients in the usual arm care received diuretics. So again, highlighting that fluid removal is a complex issue, but needs to be studied more. And this trial certainly gives us some reassurance that this can possibly be done in the future study. Until then, we rely on our clinical parameters and our individual assessment. An area that's very important is fluid removal during renal replacement therapy, because it obviously needs much more than just attaching a patient to the dialysis or filtration machine. And although we do this all the time at the bedside, that at the moment, there is no clear consensus on the optimal time of fluid removal, the optimal method, and importantly, the optimal ultrafiltration rate. And clearly, by consensus, intuitively, it's clear that if you remove fluids slowly and have a slow ultrafiltration rate, the duration of fluid overload is longer. And if you remove fluids faster, you may shorten the period of fluid overload, but at the risk of organ ischemia. And organ ischemia may occur, and it may be hidden from us. You may not necessarily see this. And this was highlighted in a paper led by people in Derby in the UK, where they conducted echocardiography in patients with acute kidney injury receiving intermittent hemodialysis. And these patients were not even in the intensive care unit. They were in the renal unit, not receiving any vasopressor support, and were considered to be clinically stable by the team. All of them had an echocardiogram done before, during, and after fluid removal during hemodialysis. And surprisingly and worryingly, the echocardiogram showed regional wall motion abnormalities in all patients during fluid removal and afterwards. They persisted after dialysis. There were also reductions in contractility seen, and the majority of patients had a troponin rise. So these patients who were not even in the intensive care unit had clear evidence of cardiac ischemia during fluid removal. Professor Teboul and colleagues in Paris showed that fluid removal should definitely not be undertaken in patients who still have signs of fluid responsiveness during renal replacement, before renal replacement therapy. We were interested in looking at fluid removal during renal replacement therapy in our cohort, and retrospectively analyzed 820 patients on continuous renal replacement therapy. And we're able to show that it was easier to remove fluid in people who had a better outcome and survived, whereas it was hard to remove fluid in those who were considered, who subsequently died, and they were often left fluid overloaded throughout their stay. But what was concerning to us was the fact that at the bedside, the prescription was often inadequate or left to the nursing staff. And we certainly showed that less than 40% of patients who were in the intensive care unit receiving renal replacement therapy had a fluid removal prescription and a daily fluid balance target. And in a detailed multivariable analysis, it was clear that not setting a fluid balance target was independently associated with a higher risk of not achieving the fluid balance target. Just again, a reminder that this is an active process which requires an assessment of the patient at the bedside and a prescription. With regards to the removal fluid, the rate of fluid removal, I've alluded to the fact that a low rate is associated with harm, but so is a high rate. And at the moment, by consensus, a rate between 1 to 1.7 mils per kilo per hour seems to be the safest rate. But again, it needs to be individualized and personalized. To help this review paper by Professor Malbrain includes some triggers that may help clinicians at the bedside to decide not to give any more fluids. Professor Teboul previously showed that signs of fluid responsiveness were indicators not to remove any more fluids. Here, Professor Malbrain showed that various blood hemodynamic targets, again, should stop the fluid removal process. And then finally, I want to just mention one more study to again remind us that there may be adjuncts to help us at the bedside removing fluid. I alluded to the fact that the risk of hemodynamic instability is higher in patients with a low oncotic pressure. And this led a team in California to look at the role of albumin administration in patients who are hypoalbuminemic. They had 65 patients who needed fluid removal during intermittent hemodialysis. They all had an albumin of less than 3 grams per deciliter, and they were randomized to albumin versus saline prior to hemodialysis and fluid removal. And patients randomized to the albumin administration had significantly less episodes of hypotension during fluid removal, and they had shorter periods where ultrafiltration had to be shortened and stopped. So in this small study, the administration of albumin in hypoalbuminemic patients who needed fluid removal resulted in more hemodynamic stability. So I hope I've convinced you that de-escalation of fluid therapy is an essential process of fluid therapy, but it is a process of care and requires a prescription and regular review. We have different tools, but all of them need to be carefully evaluated. In a simple algorithm, we can decide the options at hand, obviously diuretics or extracorporeal means. The choice very much depends on the urgency, whether solutes need to be removed or not, and whether there are contraindications to either therapy. And with that, I'd like to finish and thank you for your attention.
Thank you so much, Professor Ostermann. That was a great presentation, really thorough. We're running a little bit over time, so I've got a couple of questions. So just wanting to, the audience has put a few questions. So first, from Venezuela, which diuretic do you prefer and what dose to remove excess fluids?
So the diuretic which I prefer is loop diuretics, and they have also been used most commonly in the various studies. Now, loop diuretics work via the intratubular space, so they have to get into their site of action, which is within the tubule, and that means the dose depends on kidney function. So in patients with normal kidney function, a dose of 20 milligrams, a bolus dose may be sufficient, but if patients have reduced kidney function, they just need a higher dose to get a sufficient amount of diuretic into the tubule to its active site.
Thank you for that. Next question is around, being in a low resource setting where dialysis may not be available, what would be the best fluid removal method in patients with AKI and pulmonary edema?
So as long as patients are still passing urine, I would use diuretics and escalate the dose or use combination therapy. Combination therapy has the advantage that diuresis is induced through different modes and at different sites together, and you may overcome some of the resistance from loop diuretics, for instance. Only if really diuretics didn't work and patients were so overloaded, then I do know that in certain institutions, clinicians remove, say, 200 mL of blood, because you can also do that provided the patient is not anemic.
Excellent. Thank you for those suggestions for our colleagues in resource poor settings. And then the last question is around, can the addition of albumin along with diuretics actually increase fluid removal?
Yes. So the evidence is controversial, but there are some studies suggesting better diuretic effects in patients if albumin was administered together with loop diuretics. And the hypothesis is that the half-life of frusemide is prolonged. So frusemide is highly protein bound. In conditions where patients are hypoalbuminemic and there's less albumin around to bind frusemide, then frusemide gets broken down and metabolized faster. So by adding albumin, you essentially restore and the half-life of frusemide, make it available for a bit longer, so that it will hopefully get to its site of action. But the data are controversial. Not all
Fabulous.
studies looking at albumin have shown a positive effect, but some have.
Sure. Thank you so much. I think that's really fabulous, and I'm sure our audience will have appreciated those responses. So I'd now like to bring our session 4 to a close. It's been a fantastic session. Please join me in thanking all our speakers and the Congress sponsors who have made this possible. The presentations will start being released in May 7th, I think it is. Please follow us on socials, sign the World Sepsis Declaration and show your support in the global fight against sepsis. And with that, I thank you all and say goodbye. Thank you.